So our next speaker is Dr. Michael Sabel. He's also been a fantastic colleague here for a number of years. Associate Professor of Surgery and Chief of the Surgical Oncology at the University of Michigan. He's going to be talking about melanoma surgeries in the era of new therapies.
Thank you very much. Thank you for having me. Chris, thank you for the invitation, and thank you for everybody for attending this morning. I'm going to change gears a little bit from the diagnosis of melanoma towards what we do when a melanoma is diagnosed and the treatment, but I'd like to frame this conversation a little bit differently than we have in the past in terms of talking about what we do surgically in the treatment of melanoma, because we have a shifting landscape right now. It is a very different time in melanoma, and you just heard some allusions to how the sun is getting brighter. We're seeing these advances, particularly with the use of systemic therapies, drugs that go all over the body and can treat melanoma with several different categories of new drugs that are showing promise. And this has been after years where surgery was really one of the only options that we had in order to try to cure and treat the melanoma. And this has changed our perception of the role in surgery in melanoma. It's brought up a lot of questions from patients about why we are doing the things we are doing and how might that change moving forward in terms of the surgical treatment. And so what I'd like to do is talk a little bit about what we do surgically, frame it in the history of how we've treated melanoma, and where might this change going forward as we move into this new and very exciting era in melanoma treatment. And so I think it's important to keep in mind that when we talk about surgery, there are several goals. It's not just a matter of cure, but of course cure is our primary goal, but also staging and palliation. What does this mean? Well, obviously when we're talking about cure, we're talking about making sure that we never see this again, that we don't see it recur at the site where the primary tumor had originated, it doesn't come back in the lymph nodes, it doesn't come back anywhere, and we don't have to think about it again. But there are other reasons that we do surgery, and there are other roles for surgery in the treatment of melanoma. Staging is a very important one. So sometimes it's not just a matter of removing the melanoma, but finding out about the melanoma, learning about its biology, learning about its pathology, where has it spread, how aggressive is it, because that is going to guide those subsequent decisions that we make. And we're going to talk a little bit about the role of surgery then. And then of course there's palliation. It's not always just a matter of making sure that the cancer doesn't come back. There are situations where we will want to operate on a patient or recommend surgery for a patient because we want to alleviate symptoms or prevent symptoms from occurring, even in situations where we know that the surgery may not be extending life. And there are situations where surgery has additional benefits, even if I can't say this is absolutely extending survival. And so if we think about the different surgeries that we do in melanoma, where do they fit into this paradigm? Well, obviously, the primary surgery we talk about is the wide excision, where we're trying to get an adequate margin around that primary melanoma. And this is for cure. We're doing this so this melanoma never comes back. As you just heard alluded to, sentinel lymph node biopsy, it can potentially be curative, and we're going to talk a little bit about those numbers, but we're also doing it to learn about the melanoma, to stage the melanoma. And this is, of course, one of the most prominent questions that you get from your friends and from your family. The minute you say, I've had cancer, what is the first question you hear back? Well, what stage? And sometimes surgery is necessary in order to determine that. Quite often I can't tell the patient at that first visit what their stage is because I'm not going to know until after the surgery. We often do a lymph node dissection where we remove all of the lymph nodes. And this is a little bit of a bigger surgery. Many of you have had this surgery. And this is obviously for cure. We are trying to remove the last vestige of disease, but there's also a palliative benefit to this. Sometimes we are doing this because that disease is going to cause problems or is causing problems for the patient. And so we want to make sure that those problems don't occur, that we can improve symptoms as well as improve lifespan. And there are other more invasive procedures such as isolated limb perfusion and infusion, where we give chemotherapy directly into an extremity. I'm going to talk about this as well as patients who have stage 4 disease, where the resection of that disease, going into other organs, going into other parts of the body and removing that disease, may help with cure, but in many cases we know that it's probably not helping a lot in terms of never seeing the melanoma again, but it's helping in terms of helping patients feel better and preventing problems that may occur in the future. And so how do we balance all of these goals when we're approaching a patient in terms of coming up with a surgical plan? Well, let's start by talking a little bit about the primary surgery, the essence of surgical therapy of melanoma, which is the wide excision of melanoma. And when we think about surgery, we also have to think about the biology of the disease. Because sometimes what you see is not all that there is. And so this is a melanoma, similar to the graphic that Chris just showed, developing in the skin. But what we have to realize is melanoma has a very strange biology, different from many other cancers. And we have to think about this with all of the therapies that we apply. And melanoma has this unfortunate behavior where it can spread sort of within the dermis. And so what you see in terms of that primary lesion, what may have been removed by the dermatologist, isn't everything that's left behind. In addition, it has this, well, so you may have had this excised by your dermatologist, and you may get a pathology report back, and it says negative margins. And one of the first questions I get from patients is, I've seen my pathology report, I spoke to my dermatologist, they took it out, but they got the whole thing. So why are you recommending that we go back to the operating room and take wider margins? And that's why. It's that spread within the dermis, that extension of the disease beyond what we see with our eye, that if we don't go back and get a wider margin, we're probably looking at a 30 to 40% chance that the cancer is going to come back right in that same area where we took it out, even with negative margins. Melanoma also has this ability to spread within the lymphatics. It can spread with the flow of the lymph fluid towards the lymph nodes, and so it's important for us to determine whether the cancer has gone to the lymph nodes. Melanoma can also spread in the opposite direction. This is kind of unusual for cancers, but it can go in either direction. And so sometimes we see cancer spreading down the leg, down the arm, away from where the lymph nodes are. And so we have to think about that as we're thinking about therapy. Well now, if you think about this unusual behavior of melanoma, how you can have these little satellite lesions further and further away from what you actually see, you can start to think to yourself, if the only tool you have is surgery, then the best cure for this is going to be a wider and wider surgery. And so Chris had talked a little bit about Dr. Hanley, his recommendation for 5-centimeter margins. There have actually been a whole variety of recommendations over the years in terms of how wide we should go. And these ranged from 2-centimeter margins, 5-centimeter margins, 8-centimeter margins. Peterson in 1962, 15-centimeter margins. There were several hospitals and recommendations that you should not only go wide, but you should actually take all the skin between the primary lesion and the lymph nodes, all en bloc, meaning you removed everything together and then fill everything in with skin grafts. And Veronese, who had recommended just go as wide as you possibly can. Okay? And just like we talked about in the last talk, large areas of resection, multiple skin grafts in order to close it. And you can now sort of see the importance of the NCCN, the AAD, in trying to get these guidelines so that everybody is together on one page in terms of how wide we need to go. But in order to figure that out, you need to do clinical trials. And again, today you're going to hear about the importance of participating in and running clinical trials in melanoma so we can get these sort of recommendations that are all over the board a little bit more homogenized. To do that, we ran multiple clinical trials where patients agreed to be randomized between wide margins versus more narrow margins. I'm not going to go into the details of the study, but there were several that were done all over the world. Many patients agreed to be randomized, and that's not an easy thing. It's not an easy thing to allow somebody to just roll the dice or flip a coin and tell you how you're going to be treated. And so I can't overemphasize how much we appreciate patients who agree to participate in these randomized trials. And we're going to talk about several of them this morning. But it's these trials that led to today's recommendations of the margins of excision that we need to know that the likelihood of the cancer coming back is going to be very low. And so the thin melanoma is less than 1 millimeter. We recommend a centimeter margin. As the melanomas get a little bit thicker, that margin of excision is expanded in order to capture a wider area of the skin around the melanoma. But if you think about this, and we get this question quite often, why going so far around melanoma when in other cancers we don't do this? So a very good example, a good comparison is breast cancer. So in breast cancer, we very commonly go in and we just take out the tumor. And if the pathologist says the margins are negative, we're done. Whereas in melanoma, if the pathologist says the margins are negative, we know that we're not done. We need to go back. Well, part of it is that difference in biology that we talk about. Melanoma behaves differently. All cancers have these unique biologies in the way they behave. But in addition to that, this for many, many years, and when I say many, many years, I mean only until recently, in the past few years, surgery has really been our only option in the treatment of melanoma. So if you take out that primary melanoma, but you leave those 1 or 2 cells by not excising them, there was very little that we had in our armamentarium that was going to stop those from coming back. Breast cancer, we have surgery, and for many years, mastectomy was done in every patient with breast cancer for that exact same reason. We needed to get every one of those cells out, and if we didn't do it surgically, there was no other option. But over the years, radiation therapy, chemotherapy, anti-estrogen therapy, so the hormone-blocking drugs that we use in melanoma, have emerged. And as those new agents came into the forefront, and as we showed through clinical trials that they could kill those residual cancer cells, the surgery now changed. And it was those advances in the other therapies that led to the radical mastectomy becoming the modified radical mastectomy, becoming the lumpectomy followed by radiation, and now in some cases just lumpectomy alone. So as the systemic therapies changed, the surgery in breast cancer changed. And the question now is, as we see new systemic therapies that have efficacy, are we going to see the same trends in melanoma? Are we going to see the surgery change as a result of these therapies? And so this talk is going to focus a little bit about how those changes may happen, and it's also going to be a word of caution to not go too far until we really know what we're dealing with. I'm going to show you why I say that as well. What I'm not going to do this morning in my talk is give you a lot of detail about all these new and exciting systemic therapies, because you're about to get some talks that are going to go into much more detail and do a much better job than I could at explaining what these drugs are. I will say, however, there are several classes of drugs that have emerged that have shown tremendous promise, particularly in the treatment of patients with more advanced disease. This is where most of our data to date comes from. And you can divide them up as the targeted therapies, those that are targeting a specific genetic mutation within those cancer cells, and the immunotherapies, those therapies that are using your immune system to help fight the cancer. And they are very different drugs, and they have very different impacts. The targeted therapies, because they're targeting a specific genetic mutation, are only available to those patients that have that specific genetic mutation. So they're not drugs that you would apply to everybody, but there are tests to identify which patients are ideal. They work rapidly, they work in the majority of the patients who have that mutation, but you can get resistance, which means the cancer can come back eventually after treating with those drugs. On the other side of the coin, the immunotherapies work with your immune system, and right now we don't have very good tests to decide who are the best patients to take these drugs. And this is a very active area of my own research and many people's research. How do we identify which patients are going to respond to immunotherapies? But we're using your own cells, your dendritic cells, your T cells, your white blood cells that fight infection. And these drugs help guide that. But it takes the immune system a while, in many cases, to generate a response. So as opposed to targeted therapies, these responses can take a little bit longer. And sometimes you can actually see the tumor getting bigger before it gets smaller because of the inflammation and the immune reaction. And so thinking about how these drugs work, thinking about the differences in these drugs, how might they impact the surgical therapy of a patient? We're going to show some examples of that. So let's talk a little bit about sentinel node biopsy. And you already heard an excellent introduction about what sentinel lymph node biopsy is. We talked a little bit about it's got two goals. We want to get the disease out of the lymph nodes because if it's there, we don't want it coming back. And we want to find out if it's there because it tells us about the biology. It gives us staging information, and it can help us make decisions moving forward. As with the wide excision, I think it's very important to present this in the context of history, because we have to think about how these therapies emerged and why we use them compared to what we used to do as we think about how we continue to use them in the future. And so before the sentinel node biopsy came along, when a patient presented with melanoma and they didn't have any enlarged lymph nodes, there was no reason to believe the cancer had spread to the lymph nodes, we had a decision to make. And believe me, we argued about this decision quite a bit. Should we do what's called a therapeutic node dissection, meaning should we do watchful waiting? This is a patient with a melanoma on the arm. There is the possibility that there's cancer in the lymph nodes, but we wouldn't know unless we actually took the lymph nodes out. So the idea was watchful waiting. Let's just take out the melanoma and we'll watch that patient. Now some of those patients are going to come back with a lump underneath their arm. And when they do, that's when we'll go to the operating room and remove all of the lymph nodes. Okay? Now there were advantages to this because most patients don't have cancer in their lymph nodes, and so the morbidity, the side effects of going to the operating room and taking out all of those lymph nodes was avoided in all of those node-negative patients. But the problem is, if you let somebody recur in the lymph nodes, in the interim, in that time period before we notice that lump under the arm, is it possible that the cancer has now spread to other parts of the body? And so the other side of the coin was to take the lymph nodes out in everybody. At the same time I took out the melanoma from the arm, I also removed all of the lymph nodes. So this way, if you had microscopic disease, we got it out. Now we got it out before it had a chance to come back and potentially spread to other parts of the body. Again, here's the advantage. We get rid of that microscopic disease early, but at the disadvantage, all the patients who were node negative were exposed to this operation. The operation is a bigger operation. Many of you are familiar with it. It has the risk of swelling of the arm or the leg or other complications. And did that really help patients live longer? Remember, the goal here is cure. Okay? Yes, staging is important, but cure. And sentinel node biopsy was introduced as a staging procedure, as an idea to identify those patients who had that microscopic disease so that I could only do the elective node dissection in the patients in whom I knew the disease was in the lymph nodes, and I could spare the node-negative patients from undergoing the operation. And you all understand the concept, I think, of sentinel node biopsy from the previous talk, but we basically inject tracers. It could be either a blue dye or a radioactive tracer, or the combination, around the site of the melanoma. That gets into the lymphatics of the skin around the melanoma. It travels to the lymph nodes and highlights for me which nodes first receive drainage from the melanoma. These are the sentinel lymph nodes. So they're not an anatomic node, it is a physiologic node. It's the first one that receives drainage. If I injected the tracer in someone without melanoma or in a different location, it would go to a different node. It's a mapping procedure. And so as the surgeon, I can take out just those sentinel lymph nodes so that I can send them to pathologists, see whether there's cancer in those lymph nodes, and then, the idea being, I could go back and remove all of the lymph nodes in those patients. The sentinel node biopsy is not without controversy. We talked about the need for guidelines, the recommendations by the NCCN, who should have a sentinel lymph node biopsy, and there are many people that still argue that maybe we don't need to do sentinel node biopsy in anybody. To try to address this question, they did a randomized study again, where patients with intermediate thickness melanoma were randomly assigned to either undergo a wide local excision alone, just take the primary melanoma off, or have the sentinel node biopsy at the same time. One of the most important things that we learned is that this is truly a very important staging procedure. It gives us very important prognostic information. If the cancer has gone to the lymph nodes, there is a higher chance that the cancer is going to come back. Now, you can see where that is important information. Patients would want to know that. But if you think about it, getting prognostic information, especially when you're doing it with a surgical procedure, is really of limited benefit if I can't do anything about it. Just identifying the fact that the cancer can come back doesn't help you, doesn't help me, if I can't do anything to prevent it from coming back or lowering the risk of coming back. And again, think about this. We have been working in an era where I didn't have very much that I could offer somebody other than removing the lymph nodes. And so the question really becomes, does removing the lymph nodes improve cure on its own? Because while the staging information is important, it's not enough if I can't use that staging information to help the patient. Overall, it was a negative study. Overall, doing sentinel lymph node biopsy did not improve outcome. Well, why is that? Well, most patients in the study and most patients overall are node negative. So as you can imagine, taking out a negative sentinel lymph node, learning that the patient did not have their cancer spread to the lymph nodes doesn't actually help them live longer. It's important information and it's important to patients, but it doesn't actually help them live longer. So really the only survival benefit will be limited to those patients who have disease in their lymph nodes. These are survival curves, and what they're basically showing you is that if you are node positive, meaning if the cancer spread to the lymph nodes, getting that disease out early rather than waiting does improve survival. It improves it by about 10 to 15%. Not enough to translate to the entire population to compensate for all the node negative patients, but still of benefit. And this is one of the reasons why we recommend sentinel lymph node biopsy. A lot of people would argue, well, how do you know, if you're just limiting your analysis to the patients who had a positive sentinel node, that all of those patients would have recurred? So what are we doing? We're comparing the patients who didn't have a sentinel node biopsy and recurred to those patients who had a sentinel node biopsy and it was positive. How do you know they're the same Everybody with a microscopic cell in their node eventually develop that lump under their arm or in their groin? And the data would suggest yes. Eventually, if you follow patients long enough, the same number of patients who had a positive sentinel node are the same number of patients who recur. So yes, finding that disease in the sentinel node did stop somebody from recurring. It prevented the disease from coming back in the lymph nodes. And that itself is a very important point that often gets overlooked, because we talked about the importance of surgery in terms of palliation, in terms of minimizing side effects. If I can remove that disease now and prevent it from coming back, I can prevent an operation down the road that is going to have more side effects, a higher risk of lymphedema, a higher risk of wound complications. Because taking out the disease when it's large and bulky is more difficult and has more side effects than taking it out when it's microscopic. And so even if it doesn't improve cure, and we've shown this in several papers here at the University of Michigan, it improves quality of life. And that's an important endpoint that often gets overlooked. But just like we talked about, I have to put you under general anesthetic. There are risks. It's a second incision. And anytime you make an incision, there are risks of bleeding and infection and other complications. There's a risk of overtreatment. So we have to balance it. And when we talk to patients and when we look at their individual cases, because as great as guidelines are, every patient is different. And every patient you have to think about certain factors that might not be in the guidelines. What is the likelihood that that patient has disease in their lymph nodes? And we can base that on several factors. What is their expected survival? What are their comorbidities? Is it safe to place them under general anesthetic? If you have significant heart disease or lung disease, that general anesthetic carries rather dramatic risks, more than the benefits of the surgery. And what can I offer the patient if that node comes back positive besides the surgery? And again, for many years that was relatively minimal. But now, as we move into that era where we have potentially new adjuvant therapies that can be of benefit, this is going to shift the importance of the sentinel node biopsy. And it may be that we may start expanding the population that we offer it to, because the benefit of identifying that disease, even if that disease, that risk is low, may be greater. And so this is one area where, as our new therapies change the landscape, the surgery may change as well. The other big question that we struggle with is, if the node is positive, should we go back and remove all of the lymph nodes? And remember, when we looked at this in the historical context, we said, well, the whole idea of the sentinel lymph node biopsy was to identify those patients who should have a complete node dissection. And when we do a complete node dissection, what are we doing? We're not going out and picking out individual lymph nodes. Patients often say, when I talk about going back for a node dissection, well, how many nodes are you going to remove? I have no idea. I'm going to take out this entire pad, fat pad, where the lymph nodes reside. And it's only going to be when the pathologist goes through it that I'm going to know how many nodes I've removed. But I'm going to clear everything off the vessels, no matter where I'm operating, in the neck, under the arm, in the groin. We're usually taking these off these blood vessels, because that's where these sort of fat pads are. And I'm going to excise that, and I'm going to send it to the pathologist, and they're going to look through it. They're going to tell me how many nodes were in there, and then they're going to look at each node under the microscope and tell me whether they saw any melanoma. And today, very fortunately, because of the introduction of sentinel node biopsy, I'm usually doing this operation after I've already taken out a sentinel node, it has microscopic disease, and we have gone back to remove it. But the question is that necessary? Do all patients who have a positive sentinel lymph node need to go back to the operating room? Okay? And right now it is the standard of care. So if you look at NCCN guidelines, if you look at what people are writing, we typically do recommend all patients who have a positive node going back to the operating room. Why is that? Well, let's break this down. Let's say I have 100 patients who have a positive sentinel node. There's going to be a portion of those patients where the sentinel node was the only node that had cancer. So we take out that node. You remember the slide with the blue dye? That's the one most likely to have cancer. In many patients, it was the only node that had cancer. Never went beyond that sentinel node to any other nodes. So I can take out the rest of the lymph nodes, but it probably didn't help the patient because they were all normal lymph nodes. The only cancer that was in the nodes has already been removed. The problem is, we can't tell you that. We can't predict or identify which patients the sentinel node will be the only one, and those patients who are going to have additional disease. We can make estimated guesses based on the burden of disease in the node, meaning how much cancer do we see in the lymph node or other factors, but even those are just guesses. There's going to be another portion of patients where unfortunately it spread to the nodes, but it also spread someplace else. And in those patients, taking the lymph nodes out is a little like closing the barn door after the horses have left. I may have taken some of the disease out from the nodes, but there's already disease someplace else in the body. And again, I can't tell you which patients those are going to be, and I can't tell a patient who they are. We can get CAT scans, we can get PET scans, but this is usually microscopic disease that isn't going to show up on a CAT scan or a PET scan. And again, a very common question I get from patients, well, why don't we get a PET scan, and if that PET scan's negative, why do I need to go back for the surgery? And again, this is for microscopic disease. This is not something we're going to see on those studies. Take another chunk of patients. These are patients where if I didn't do the surgery, I would leave disease behind in the lymph nodes, and it would come back, and in a year or 2 years, they would develop this lump, and I'd take them back to the operating room then. And yes, the operation, as we just talked about, has more side effects, more morbidity, but I'd still do it. But it still hasn't spread anyplace else in the body, so even though that operation was delayed, the patient is still cured. As I show you these blocks, they sort of look like 25%, 25%, but we don't know. We don't know how many patients would fit into any of these categories. And the final category is the one that we are worried about. This last group. Because these are the patients where they did have disease in their other lymph nodes, and if I had taken it out, it wasn't anyplace else. But in that time period, between when I would have done the operation and when I'm now doing it, because they've recurred, it has now spread someplace else. And I have lost an opportunity to cure somebody. And so this is why the complete node dissection remains the standard of care. This is why we recommend it. But if that's a very tiny percentage of patients, if that's 1 or 2 out of the 100 patients that we're talking about, then I'm subjecting 100 patients to a surgery to help 1. Is that worth it? Again, if you ask doctors and if you ask patients, you may get very different responses, just like what we just talked about with the adjuvant chemotherapy survey for women with breast cancer. If I said that 1 out of 100 patients benefit, I know that 1 patient would tell me it's worth it. But would patients want to do this? And we don't know that answer. But if that is a bigger number, if 10% of patients, 1 out of 10, benefit from the surgery, then we probably should be doing the surgery. We should be removing that disease. To help answer that question, this is the next randomized study that we have performed. This is MSLT-2, where patients who had melanoma, had a sentinel node biopsy, and the sentinel node biopsy came back positive, could be randomly assigned to either have that complete surgery, where we remove the rest of the lymph nodes, or they could undergo observation, and we would do ultrasounds of the basin to see if we could detect the cancer coming back as soon as we can detect it, but basically it was a randomized surgery versus no surgery. And there may be some of you who participated. We have about 50 patients on this trial here from the University of Michigan, but it has finished accruing because of many generous patients who volunteered to be randomized, but we don't have any results from it yet. So this is a question. We are waiting for the results, but it's probably going to be a few years, because obviously we have to follow patients for a while to really determine that it's safe to not do the surgery. But again, we started this clinical trial before we had any adjuvant systemic therapies, where the idea was if we can't cure it surgery, we can't cure it. And now we're in a different era. And so now the question becomes, how are these new drugs, if they are shown to be effective in the adjuvant setting, meaning if these drugs are helpful in patients that have had surgery that have no evidence of disease, how does this affect the surgery? Well, it is possible that it could shift these numbers. So for example, sentinel node only disease, meaning I've removed the disease with just the sentinel node biopsy. It's not that I wouldn't be leaving behind disease, but if these patients start getting other therapies, these systemic therapies that we're talking about, and that could eliminate the remainder of the disease in the lymph nodes, the benefit of my surgery goes down quite a bit. And again, getting back to that comparison between breast cancer and melanoma, this is exactly what has happened in breast cancer. In breast cancer, we had a trial, it was called the Z11 study. It was the same study that I just showed you, the MSLT2, where patients who had a positive sentinel node in breast cancer were randomized between the complete dissection, which was also the standard of care in breast cancer, versus no further surgery. And that study showed no further surgery was perfectly fine, that it didn't benefit patients. And it wasn't because we weren't leaving disease behind, it was because these other therapies, chemotherapy, anti-estrogen therapy, radiation therapy, which is commonly used, took care of that residual disease. Moving forward, we could see the same thing in melanoma, where the complete node dissection may not be necessary, A, because these patients don't have additional disease, or because if they do, the other therapies take care of it. The opposite could be true as well. We could see that these drugs are very good at taking care of cells that have already spread someplace else. They may improve survival, but they may be less effective at taking care of disease in the lymph nodes. And that would increase the importance of clearing the nodes. And it's important to keep in mind we can't make assumptions. We never do well by guessing what the melanoma's biology is going to be, because it will always fool us. All right? And that's the importance of studying this and doing these sort of clinical trials. Of course, not all patients have that microscopic disease in their nodes. There are still those patients who come in, and at the time we diagnose their melanoma, they have that lump underneath their arm, or lump in the groin. We can feel, we can see that the cancer is not only in the lymph nodes, but it's gotten a little bit ahead of us in terms of its size. And here's a situation where we need to go in for a much larger volume of disease in the lymph nodes. It's pushing out on the skin, you can see it, you can feel it, and it's getting a little closer to those vessels. And so, again, before we had any effective adjuvant therapies, before we even talked about these systemic therapies, surgery was the only option in these cases. And even though there were more side effects, and even though it was a little bit of a more difficult surgery, if we couldn't do it, there was no other great choice. And so that's why we would do these node dissections. And so today a lot of people say, well, I read in the news, I've seen on TV, I heard about President Carter, there are all these new drugs. Why do I need surgery? I have this big bulky disease here in my groin, I have this underneath my arm, but why not just do the drugs? And that is a very legitimate thought. We call this neoadjuvant therapy, the idea that we give these drugs before the surgery with the goal of shrinking that down so that now the surgery is easier with lower side effects. Why not do this in everybody? Well, there are risks and there are benefits. It is something that we are doing. In patients where I don't think I can do the surgery or where I think the risks would be exceptionally high, this is just one example from the literature. Somebody who had a very large lymph node, shrunk it down with these new systemic therapies and allowed the surgery to take place. And we have many, many examples of that. So shrinking the tumors allows for an easier surgery, and these patients we know have a high likelihood that the cancer, the melanoma could come back someplace else. So why not use these drugs to treat not only what we know about, but the disease that we don't know about? Well, to some degree, we've been a little bit stuck with what has been a catch-22. If I say that I can't resect the disease, these drugs are approved for the use of unresectable disease or metastatic disease. But if I do the surgery, then these drugs are not approved as an adjuvant, as an additional therapy after surgery. So if I don't give the drugs ahead of time, we probably can't give the drugs at all. And then that benefit of maybe treating disease elsewhere isn't there. And this is quite the dilemma for patients, for doctors. So why wouldn't we just do it? Why don't we just give the drug? Well, there are risks. We don't know whether these drugs work in the adjuvant setting. We don't know if there's going to be a response. And in some cases, that tumor might get bigger. And I could face this situation where I didn't shrink the tumor, but because you either didn't respond or the drug didn't work, it actually got larger. And now I've taken a case where the tumor was resectable and potentially curable, and now it's not resectable, because now it's involving those vessels that are nearby. And so this is why we need to study this. We can't just sort of make those assumptions and say, well, why don't we just give everybody the drug, because it may not work, and I may have converted a situation where I can treat to a situation where I can't treat. It's also very important to understand that because a drug works in stage 4, where we are treating known metastatic disease, is not a guarantee that it will treat in a patient where we have operated on them and there is no evidence that there is disease. Because even if that disease is still present, it's different disease. It functions differently biologically. When you have a large mass that you are treating, those cells are actively growing, actively dividing. But in many cases, when you have just microscopic disease laying low in the rest of the body, it's what we call dormant. And it's different, and it doesn't respond to drugs the same way. For this reason, we've had many, many drugs that have worked in stage 4 that we made assumptions would work great if we give them to patients who had surgery and had no effect. And so this is why we need to do clinical trials. This isn't as easy as saying you can just do it. There's differences in the blood supply and how those cells not only get their nutrition, but get the drug. There's differences in the cells that surround it, like the immune cells. So if you're counting on an immunotherapy, but those dormant cells are sort of invisible to the immune system, then those immunotherapies may not work. And this is why we have to wait for those clinical trials to decide. There are other areas where the impact of new therapies has changed our surgical approach. This is in-transit disease. Remember we talked about how those cells can spread in those lymphatics in either direction. You can get those dermal metastases, those little black spots of melanoma up and down the leg. This is somebody who had a skin graft in the past. It's recurred under the skin graft. It's recurred in other places. And we have, for many years, approached this by giving high doses of drugs to the leg to kill those cells. But now, with new effective systemic therapies, that paradigm is changing. This may not be the first choice in therapy for those patients. And of course, there are situations where we do want to do surgery for metastatic disease. We talked about that early in the talk, those patients where the cancer has already spread to other parts of the body, and yet, is there a role for surgery? And very briefly, what I will say is there are pros and cons to this. So even in an era where we have these new and effective drugs, there may still be a role to go back and remove that disease. A lot of people would look at this and say, well, if the choice is between taking a drug and doing surgery, I'm always going to choose taking the drug. And that comes from a time where surgery was much more invasive, the side effects were higher, but we have better anesthetic techniques, better surgeries, lower side effects, and we can do very major surgeries with many fewer side effects. The response is instant. We don't have to wait for months to see whether or not the drug is going to work or not. As soon as I'm done in the operating room, that cancer is out. We can do this with few side effects. It is relatively inexpensive, and I don't just mean to society. The co-pays, the costs, the time off of work could be considerably fewer. And so, it comes down to a balance of many, many factors when deciding what is the right approach. Should it be surgery? Should it be systemic therapy? And based on what do we know? How strong is the evidence? How well can we assure somebody that these systemic therapies will work? So, what are the implications, as I conclude this talk, of the new therapies on the surgical management of melanoma? Well, we're already seeing how these new drugs, these exciting new developments in melanoma are changing surgery. We're doing less of the limb perfusions, altering our approach to the local therapies for metastatic disease. And potentially there's more changes coming. This could change our approach to sentinel node biopsy. It may increase the number of patients we recommend sentinel node biopsy for, or convince people that everyone with melanoma over a millimeter should have a sentinel node biopsy. It may impact our decision to go back and remove the rest of the lymph nodes in patients who are sentinel node positive. But we must make caveats for this. We must be careful and temper our enthusiasm. We can't make assumptions without evidence. We have a long history of therapies that looked extremely promising and were extremely effective in stage 4 melanoma. IL-2 being a very good example. Worked very well, very many potential benefits to IL-2 in stage 4 disease, did not really translate when we used it in the adjuvant setting. There's different biology between that microscopic disease elsewhere and the metastatic disease that we're treating. There's differences in biology and there are different goals of treatment. Different side effects patients are willing to accept when you're talking about improving the chance of cure versus treating what would otherwise be incurable. And this is the importance of clinical research and trials. The bottom line is this: it is not so simple anymore. Melanoma was a surgical disease for many years. You saw the surgeon told you what needed to be done, and then when you were done with surgery, the surgeon decided whether or not you should go see a medical oncologist or not. It's not that way anymore. These are complex decisions that need to take into account many different factors. And so we need a more multidisciplinary approach to the treatment of melanoma. We need to discuss this case and outline a treatment plan by incorporating early on the medical oncologists, the surgeons, the dermatologists, and get input from the pathologists and the radiologists so that we take as much information unique to that patient so we can target their therapies specifically to what would be best for them. There's no more one-size-fits-all approach. And this is a very rapidly changing landscape, and you need to sort of adjust for that as we learn new and new things about melanoma, which almost seems like on a monthly basis at this point. Thank you very much for your attention, and thank you very much for the invitation.